I want you to take that even a little further back from supportive care to ABCs. Oh, I lost you there. Oh, there you are. I got you. Okay, I'll be here. Okay. Yeah, yeah, but when you have a relatively limited patient scenario that's presented, take it from like your what we traditionally teach you is like BSI, scene safety, number of patients, mechanism of injury, nature of it. Like go through that for every like patient scenario that you have to get the most appropriate answer. I think is the best way to approach that. Good, good. Sounds good. All right, cool. So we've got let me share. I've got a where's my share? Yep, we're recording, so let's hopefully. Hi, everyone. When we all, goodness gracious, yeah. All right, hold on, me. Oh shit! Come on, roll, 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 roll. Mm, 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 mm. All right. So EMS is dispatched to the emergency 911 call for the unconscious patient. Upon arrival, 32-year-old male patient found lying on the floor, responsive to painful stimuli. Patient's mother called 911 for the patient, stating that he is a competitive bodybuilder and started to complain of chest pain while exercising. He was clutching his chest, so she gave him one of his father's nitro tablets. He has a history of a mitral valve murmur. Mother denies that the patient takes any medication, but states that he takes, quote, herbal supplements and pre-workouts. He has no allergies. Current vitals are 70 over palp. Respirations are 24 and regular, not irregular. Let me fix that. Pulse is 122 and his SpO2 is 96% on room air. So let's start. I got good color. So what are our differential diagnoses? Okay. He was working out. And then he started experiencing chest pain, was clutching his chest, and she gave him a nitro. So toxicity. Mm-hmm. Okay. All right, so... All right, go ahead. Sorry. All right, so let's go with med supplement interaction. Right, so if he was taking pre-workout, the pulse of 122 might be somewhat expected. If he was also exercising, he took pre-workout, 122 might not be completely out of the norm. Good. So, what is our course of treatment? How would we do that? All right, so if you think that he's going to vomit, I'm all about the nasal cannula. Love the nasal cannula. Yeah, we're gonna go vomiting. Ugh. All right, so we've addressed airway. We've addressed breathing, right, and positioning. This is a little bit. What else? Okay. Yeah, this is the patient where you're like 14s. 14, 16. I personally like the 16 gauge. And we talked about this last review a little bit, that the 16 gauge, depending on your agency, of course, the 14 gauge IV tends to be 14 gauge by 1.75 inches, where the 16 gauge is by 1.1 inch. So your resistance is approximately 0.6 inches less resistance. So you actually can get more fluid in with less resistance against the catheter. Okay, so IV, and I'm assuming now that we have large bore, what are we going to attach to it? Okay. So, and this is going to depend a little bit on your patient. Let me just change colors real quick. So you have a 32-year-old male patient who is a competitive bodybuilder. So while it's a young patient who will most likely tolerate fluid well, sometimes there's certain like groupings of people who might actually do damage to their hearts due to the quote unquote supplements that they take, right? So a lot of these bodybuilders do take testosterone that may or may not impact their heart. So that's just something to take into consideration. But generally, this is a patient who would be able to tolerate this well. How would you make sure that they are in fact still tolerating it well? Okay. Mm-hmm. But in terms of fluid, how do you know that the fluid is not causing more harm than good? Perfect. That's exactly what I was looking for. Your lung sounds, that's going to be your tell all. Put them over here. Lung sounds. Lung sounds are essential when you are administering fluid to any patient. Oh, absolutely. And also, depending on how the airway is secured, so if you have a patient who you may have intubated, you may actually move that over. You may have frothy sputum start coming up, and that's a real telltale sign that the fluid is going in a bad spot. So back in maybe 5 years ago, they were doing cold fluid therapy for cardiac arrest patients, trying to see, because in cardiac arrest, in order to lower the myocardial oxygen demand, they drop the patient's core temperature. In the hospitals, they use what's called the bear hugger to drop the core temperature to, I believe it's in the low 90s. Don't quote me on that. So what they do is they drop the temperature, they slow the metabolic rate down so that basically the whole body can heal. Essentially, the heart can heal without really drawing too much demand from the body's metabolic. We don't need a lot of calories, we don't need a lot of oxygen, the heart's healing. And then as the patient has like this rest period, they start to bring them back up to temperature. So the thought was, we can start doing this cooling therapy in the field. We'll start pumping these patients full of 1 to 2 liters of cold fluids. It didn't work. So the whole problem was, one, you were ending up with a lot of patients with pulmonary edema because, one, they're dead. So their cardiac function is crap. And 2, they're sick. And 3, the temperature wasn't being dropped enough to be significant. So it just wasn't effective. So they did this whole trial period in New York City to actually conclude that it wasn't going to work. So they pulled all the cold fluids off the truck, ironically, right after everyone had installed coolers in the truck. So that was like, you would have to, like, when you pulled up on scene, you're like, oh, under cardiac arrest, you would have to go and grab like 2 liters of cold fluid and like run to the scene like the Peanuts character. But I can't tell you the number of times that you're pumping this cardiac patient who's in full cardiac arrest, you're pumping them full of cold fluid and it's just coming right back up the tube. And then you'd have to shut it down. Yeah. So lung sounds, absolutely essential. And this is, we tell everybody when you're on the truck, you have to make sure that you check lung sounds. It's a real essential part of the patient assessment that kind of gets overlooked and gets kind of dismissed a lot. Like, people, how do I put this? people just kind of forget about it, and not necessarily like in a malignant or malicious kind of way. It's just like you walk in and you're like, oh, the patient's having a heart attack, and like lung sounds are not necessarily the first thing on your mind. You're getting an IV, you're giving aspirin, you're giving nitro, you're doing all these things, and then you're like, get to the hospital, you're like, oh, we didn't do lung sounds. But then meanwhile, you walk in, the patient's going, you're like, oh, they're wheezing. And like, some people will make sure they get good lung sounds and see all fields, like where the wheezing is. And then some people like just throw albuterol at it. So it's one of those things that people kind of forget how to do or to do. So I know on my truck anyway, I push like to get the lung sounds. But in regards to this patient, so we've said, get a cardiac monitor, 3 and 12 lead, get your lung sounds, start running fluids. So if you start to run fluids for this patient, get green, I like green. I do green. What would you expect to happen? Okay, so good. So is it hypovolemic or hypercapacity? Mm-hmm. Yeah. So basically, the function of nitro, right, is to expand the diameter of the blood vessels, thereby expanding the capacity of the intervascular space. Ugh, that just got stuck. So if you have a healthy patient who is well balanced, right? You're in equilibrium, where the amount of blood that they have is equivalent to the container that it's in. And then you change one of those things, whereas the container size is now larger. Yes, the patient is hypovolemic, but it's not because they're lacking in volume, it's because their container is too large. Exactly. So, with the administration of fluid, you notice that your patient starts to improve. So your patient, I'm trying to get a color I don't have yet. So after, so you've given your fluids, the patient starts to wake up. But now, what would you ask the patient in regards to the complaint that he had prior to the nitro administration from his mother? Okay, so if the patient says he had an acute onset of sharp chest pain, unilateral chest pain, after doing flies, what would you expect? What's your like immediate thought? And here is one of your zebras. Oh, 100%, 100%. And most, like I want to say like 99% of the time, it's going to be a horse. But sometimes you have a perfect storm of events where you have an unconscious patient who's coming across, he's having chest pain, he fell unconscious, and you're like, yes, this is it. This is going to be something really great. And then you show up and he's like, I pulled a muscle and my mom gave me like my dad's nitro and I passed out because like his blood pressure was like, now, if this patient said, I started having chest pain and it's a tearing sensation, let me find another color, and it's a tearing sensation, perfect. Absolutely, and more of a just a traumatic, significant problem, right? Because like, here's your, well, let me clear everything because like, I think we're pretty much done with this one. So, right, so you have your heart. It's a nice, super sexy looking heart. And you have your aorta. Boop, 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 boop. So, depending on where the tear in the aorta is, right, you could end up with, hey, that didn't change colors. You could end up with the aortic valve being compromised, right? So if you have a tear here, and what essential component of your life hides right behind the aortic valve? Which ones? All of them. Yep. Let me try not to spell it wrong. The essentially the opening. So like, if you look at like the aortic valves like being kind of like right here, and here's the aortic wall, as it is, well, that's a bad picture. All right. So as they open, the opening to all of the coronary arteries is like right here. So right, so as the heart experiences systole, it opens the aortic valve. It comes across, sort of like, think of it like the epiglottis. You know, you take a deep breath in, the epiglottis opens, it covers the esophagus. So as the heart pumps blood out, the aortic valve opens and covers the coronary artery. The opening for all of the coronary arteries. And as it experiences diastole, it relaxes and the blood backflows and goes into the coronary arteries, feeding the heart. So you have your main coronary artery, and then you have your left anterior descending, and then you have your left circumflex, and then you have the right coronary artery, right? So everybody comes off of this opening right here. So if you have this is messy. If you have a aneurysm that impacts like this area right here, you're going to have significant decreased blood flow to the heart, to all the coronary arteries, which is going to show up as like a really funky looking EKG. The patient might be unconscious. The patient might be experiencing significant tearing pain. The patient might not be able to tell you what's going on at all. Another fun medical fact is that young men are the #1 demographic to experience ruptured coronary arteries. So if you have someone who's putting himself through significant strain, right, especially bodybuilders, right, they do that like that build cut kind of phase. So they're like, oh, I'm going to build. And then all of a sudden they're cutting and they're taking all those diuretics and they're like really reducing the amount of fluid in their system so that they look really good, really, if they're experiencing that, you know, they might actually put their coronary arteries at risk just from that strain. Especially like this is one of those things where like the more you kind of know about like people's hobbies. So I had a bodybuilder once. She was preparing for a meet, and her mom was doing her spray tan, and she had a syncopal episode, because she had spent 3 days taking Lasix and pulling all that extra fluid off of herself, so she was kind of dehydrated, and she up and down. She was young. She was like in her like late 20s. She's like, I'm not going to the hospital. I'm not missing this competition. And I was like, girl, I get you, but you got to drink a little bit of water. Like this, if you drink some water, we can make an agreement. And like that was it. Like it was fine, and she was okay. But like you have to kind of understand like the processes that certain people do. Like if you had a patient who was an anorexic or bulimic, like these are all those like kind of special little characteristics. And once you start to piece that puzzle together, you'll get a better view of the patient and what it is that they might be experiencing. So, thoughts, questions, concerns? Okay. I will. It comes a time. It comes a time, yeah. Okay, fantastic. I have I'm working a tour 2. I think I got a tour 2, and I might have a December 3rd. I'll look at FizzDap and see who's on. But yeah, unfortunately that's what happens. It's a popular truck. I know. I have mixed feelings about that. I do think you do need to expand your horizons a little bit in terms of like who you work with, because when you know your medics and the medics know you, they're either going to be like, here, free reign, and not critique you, or they're going to be a little more overly critical. Like, if that makes sense. Like, if they like, we really don't like him, we know that if he gets his medic, he's going to go for an upgrade, and I don't want to work with him, then they're going to like kind of sabotage you. If they're like, I know you, you're strong EMT, you're going to be a great medic, I'm not worried about it, like, you just get like all fantastic scores. So, and you don't learn that way either, which, you know, you need people. Yeah. Mm-hmm. So yeah, so it's a lot of knowing what your anatomy is. So like if you look, I don't know if you can even, I don't have a great view. So you have the antecubital space, right? So hold on, let me stand so you can see my arm. right? So you have the antecubital space. So there's commonly, and you can see here, that vein right there. See that bulge? Okay, so usually it will either be an H shape, so you'll have here and like another one here, and then maybe one that kind of comes across this way, or you'll have a W shape. So this, instead of it being straight, it'll go up this way, and this one will go this way. And then there'll be one that kind of goes. So there's two shapes when it comes to the AC that are very common. So I can't tell you the number of times when just knowing that and being like, I can't feel anything, but I know it's there, and just boop, and you just get flashed right away. Yeah. Oh yeah, absolutely. So doing an IV while you're moving is a whole new skill set that you really have to kind of time it and know the roads. And being on the truck, like, and knowing the roads of Jamaica, like I can tell you, like, there's parts of Jamaica Avenue from like 128th Street to like 134. Like, don't even try. Like, it's all potholes. Hi Ashley. She did. So like I wouldn't even try an like IV there. Like, but also, like, even though he had fantastic veins, those are also veins that are gonna pop really easy, because if you hit them like dead on, it's so much pressure in that vasculature that it just goes poof. And that's, I think, what happened with the first one. Also, those veins have a lot of valves. So, and if you look, it looks like a little bump. So like maybe check your own vasculature, because I don't have anything really rocking right now on mine that I can use in as example. But it looks like a knob, like a little, like, it'll be like vein, bump, and it keeps going. Those are usually where the valves are. And if you start in the valve, like right there, or like behind the valve where you might actually hit, like the end of the catheter is going to be right there, it's going to be unsuccessful. So you have to like kind of coordinate where you're entering the vein. And you can kind of be creative with that also. Or bifurcations, right? So like if this was your AC and you started here and you go up, the end of the catheter might end up against the wall of the vein here, and you're gonna be like, why isn't this working? But you pull it back a little bit and it's perfect. Also, and this was what I wanted to do with the lady who we had the anaphylaxis, you can take a little tape and wrap it around the IV lock and pull it back to hold traction against it, so it's in the like perfect spot. There's a lot of little tricks that you'll start to pick up from different people. Some people have really great tricks. Yeah, no problem. And never hesitate with the Zofran on a vomiting patient. Most likely. No, I think, you know what? I also think just based on his demeanor, he kind of gave like an autism vibe, like maybe like a poorly managed or undiagnosed autism spectrum, based on his like the rocking and the repetitive statements. Like, I feel like that was maybe something that's not being managed well. Yeah. Okay. I have one more scenario since Ashley just popped up. I'll do. But I think she went to go get snacks or coffee. So. Which, like, 110% do not feel bad about. Go get those. Ashley. Okay, we're gonna do another scenario. Are you like getting coffee? Delightful. That's even better. All right, I'll give you a minute so you can come join us for this. All right, cool. Let's do it. Okay. All right. So EMS is a dispatch to the emergency 911 call for the inbleed. Upon arrival, 30-year-old female patient meets the crew at the ambulance, the best type of patient, saying that when she went to the bathroom a little while ago, she had diarrhea with frank red blood. She states that this happened to her in the past, but never with this much blood. States she is an alcoholic who usually binges for 2 to 3 days. Her last binge ended this morning, and her last drink was approximately 8 hours ago. Patient is violently shivering and states that she is nauseous. States that this is her usual withdrawal symptom. States that she has a history of hyperthyroidism and was told 2 months ago that her thyroid levels were normal and she should stop taking her medications. So, off the bat, let's do our differentials. Ashley's phone's making me nauseous. No problem. Okay, good. What else? So with dehydration, your blood pressure can stay pretty good and or be elevated until like you totally crash. Okay. Okay. What would you want? Come back. All right, so we've got lower GI bleed. So in terms of signs and symptoms, so we've got the frank red blood. What else can cause frank red blood? That's kind of run of the mill. Hemorrhoids. Hemorrhoids. All right. So hemorrhoids, right? So now think of esophageal varices, right? So like you have that buildup of like that backing up of blood from a cirrhotic liver that's building up into the esophagus, causing engorged blood vessels. The same thing can happen in the rectum/anal region. So frank red blood is potentially a problem, but at the same time, it could also just be something simple like hemorrhoids. So, what else? So let's move on to alcohol withdrawal. What are some signs symptoms of DTs and alcohol withdrawal? Okay. Tremens. Thank you, Ashley's partner. What else? All right, so if I told you that the patient started dry heaving and vomiting during transport, what would you think? Okay. Okay. So, quick question: what would you do for? And this is I'm gonna Ashley. This is all you. What would you do for a patient who has severe nausea, vomiting? How much? With a repeat of? Beautiful. And I'm going to tell you this because I told Joe this when he was on the ambulance with me. You don't have to hesitate for Zofran. If the patient's going, huh? Like just like that just making that face, you know, the face, like the face, just hit them. Just give it to them. Because it's just not worth it cleaning up vomit when you can fix it with Zofran. It's the best medication. It's one of my faves. You're like, what's that? No, Zofran. Okay, so if you do happen to have a patient, though, that you're going to give Zofran to, what other considerations must you take? Thanks, Dave! There you go. So how would you find out if the patient has long QT? Perfect! So now let's do, hold on, I'm find a good color. I like this one. So let's talk about the EKG. Even if the patient is not, this patient in particular, right? The patient states that she has a history of hyperthyroidism. Even if you were like, she's not in the vomiting region. Oh, we're moving. Oh, we're moving. Okay. Even if the patient's not in the vomiting region, would you want to do a 3 and a 12 on her? So what are some complications of hyperthyroidism? Let's go over here. Back to signs and symptoms. What's that? Okay. It's also a sign and symptom of dehydration. There you go. Okay. And dysrhythmias as well. So even if this patient was like, I just have a history of, you're like, okay, you know what? Let's do a 3 and 12 because you know what? Maybe you find your zebra. Maybe she's having a hyperthyroid storm, which would be wild. But at the same time, then you're that medic who shows up saying, I did my full assessment on this patient and I found this. She has a history of hyperthyroid. Look at this wild rhythm. And they're going to be like, ooh, let's fix that, right? Like, then you don't look like the asshole who comes in and says, like, I don't know, she's a drunk and she's got hyperthyroidism. And meanwhile, her, like, heart's ticking away at, like, 190. So it does not hurt to be thorough. Okay, I guess is really the point that I'm trying to make. So hyperthyroid even if they're on their meds, they can still have it. It's like just an extreme release of the thyroid hormone, so that they will be tachycardic. They might be extremely anxious. They potentially will have a very high core body temperature. So pretty much everything that's associated with your metabolism amping up. Like, think of like if you had gone and decided to run a marathon, like that is a lot of the same stuff that you're going to kind of experience with a patient with hyperthyroidism. It depends. You really might. Like, they might be presenting like feverish. I've seen anxiety attacks really, really go. I spent an hour and a half on scene once trying to calm like a 16-year-old kid down. It wasn't just a tachycardia. He was so anxious that he hyperventilated himself into blindness. And his hands were like doing the full carpal pedal. He was just like curled up into a ball. He couldn't see anything. He was like, it can happen. But it's definitely good to think of other things going on. 100%. Like, because it does, like, usually anxiety is relatively self-limiting, right? They like, and then they pass out. And then they're good. And you're like, all right, cool, like, reset. But if it doesn't, like, if hyperventilating is not really like one of the major symptoms of their anxiety attack, then they can really just go. Yeah. Ashley, how's your night so far? Does it actually even come in a cherry cup? Oh, okay. Because all I saw was CH, and I was like, "Damn, that's impressive." Chill, y'all. Also drinking cherry. Definitely didn't think there was this much. I just re-poured, and I was like, "Oh, that's way more than I wanted." Oops. So yeah, so that's really anything else, like I guess for this patient. So like we kind of covered the Zofran aspect. We covered the making sure that we do the 3 and the 12. Is there anything else for this patient that you would maybe consider or want to kind of cover? And you are also allowed to say no. Remember, not every job is like in its super intense ALS job. Okay. Okay, Ashley? Okay, good. Cool beans. So, any other thoughts, questions, concerns? I recorded the first half because I know you came in for the second half. Anything good? What you got? She's like, no. Was it good? Okay. It was, except for the CPR part, it's an interesting job. I mean, bystanders, though. It was a nursing home. Even more ridiculous. Hi, I'm a medical professional. We did CPR. Why? I don't know. We're putting it for the save, though. Lord. We had a late. Okay. Yummy. Woo! Is she neurologically intact? Oh, that's impressive. That's I mean, that's good. How old?